Muchas gracias por su conferencia y por estar aquí. Simplemente era ver si podía profundizar un poco más en el criterio de no abandono, que es uno de los que tiene probablemente fuerza a la hora de movilizar a profesionales que han tenido dudas en ese acompañamiento, ¿no?
So I can talk most clearly about the United States, where our system is very fractured. So in the United States, if you have a cancer diagnosis, for example, and you get really sick, as long as you're taking cancer treatment, you will have plenty of people around ready to take care of you and commit to you. But stopping that treatment, then it becomes a very open question: who's going to take care of you when you stop cancer treatment? Is it the oncologist? Do you go back to your primary care doctor? Do you see a palliative care clinician? And so, in my opinion, we should be challenging both our primary care system for the primary care doctors to stay involved, even as people get really sick, and they may be predominantly under a cancer specialist team. Or our oncologists, if they've worked with somebody for a few years, they've lost touch with their primary care doctor, and now the patient is entering the last phase, they need to stay involved. So it is some commitment to stay involved throughout the process by people who know you. Now again, if all else fails, palliative care can come in and do that, and we do have some expertise in that phase of life. But that continuity might get lost in that process. And the continuity, I think, is a vital part of medical practice, has been so from the beginning of medical practice, and it's shaky right now, at least in the States. I don't know how it is in Spain, but it's much more shaky than it's ever been. And that's a huge loss if it gets lost. So we need to try to set up systems that reinforce that, get people back into people who know them, and encourage the people who know them to stay involved.
Buenas tardes. Sí, hola, doctor Quill. Bernabé Robles, de Barcelona. Hemos hablado de tener precauciones con el trastorno mental en las decisiones, ya sea de suicidio asistido o de eutanasia. Se han dado peticiones de pacientes, por otro lado, competentes, con sufrimiento insoportable por patología mental, en las cuales el trastorno mental no es un factor de distorsión para hacer la demanda, sino es la causa de la demanda. ¿Cómo posicionarse en estos casos en los que la hipotética muerte no está tan cerca, pero el sufrimiento es irreparable e insoportable?
Yeah, I always hate this question, so thank you for asking it. Because it's a very challenging question, right? Because the desire for death is part of severe depression, right? And so, and in theory, most of the time that will disappear when the depression is treated. So what happens if it's treated and treated and treated and it doesn't disappear? And again, so these are, I think, the most challenging cases because they're not going to meet the terminality requirement. If a terminality requirement is there, they're not going to be more likely than not to die in the next 6 months by natural causes. And the desire for death is part of the illness that theoretically could be reversible. So I'm probably still more on the conservative end on the response to this than other people. I think other people who are a little more radical in this area than I am would say, well, depression is like any other illness, and it clearly has biological components, so why should we discriminate against people who have depression? And those are arguments that I think are very powerful. But I still get stuck on the experience that it is part of the illness, that distortion is part of the illness, and that the people that I have cared for who have wanted this over a long period, because I'm a safe person to talk to, and I've talked to people over literally 4 and 5 years about this, and they haven't killed themselves, number one. And I feel like I would have been, it just didn't feel right. So I just couldn't bring myself to help them in that way. So I think we should keep struggling with those patients. I think you could make an argument that if you were to allow it for such patients, you would really want extremely competent and experienced psychiatrists and medical people seeing the patient before it happened, because I'll probably say something, I don't know how many psychiatrists are in the audience, but the number of psychiatrists who are used to seeing really, really sick medical patients is not that high. So again, you're used to seeing patients who are purely psychiatric. In some of these tough cases, you'd really want somebody who has a lot of experience with these cases, providing the second opinion and making sure you've looked at all the alternatives. So it's a challenging area for which I don't have an easy answer. Yeah.
Soy médico de familia de Granada, de España, y uno de los mayores problemas que tengo con los pacientes al final de la vida es la identificación de las transiciones. Retomo un poco la diapositiva que ha puesto usted antes, lo difícil que es identificar la transición desde ya la cronicidad irreversible a la terminalidad y la segunda transición de la terminalidad ya a la situación de agonía o de últimos días. Si no identificamos correctamente esas transiciones, nos resulta luego muy difícil pactar, dialogar, comunicarnos, deliberar con los pacientes respecto a cuál es nuestra propuesta de atención. Supongo que no tendrá una solución, pero al menos una recomendación.
First of all, I totally agree with what you say. If you care for people throughout these processes, the clear-cut transition from one phase to the other is often not there. Although I would say the transition from when you're undergoing aggressive disease-directed therapy to hospice is a little bit clearer than most because you reach a point where the burdens of treatment are starting to get very high, the odds of them working are very low, and you really have to have a frank conversation with somebody. And I think I applaud you if you're, as a primary care doc, you're in a better position than anybody to help people have that because you don't have a vested interest in how it comes out, right? And then as on the other hand, somebody's been on hospice and they're nearing the very end and they're wondering whether, does this make any sense anymore? Again, it's just a time that somebody whoever knows the patient best has to sit down and sort of explore it with them. Are you really at that stage? Have we looked at this from all possible angles? And it's really, it's mainly a listening task and an exploring task rather than an advising task, although I do think that sitting down, listening, exploring, looking at from as many angles as you can think is a really vital task. And it's key to identify who's going to do that. And it should be, in my mind, the person who knows the patient most and cares about him the most.
Muchas gracias. Vamos a hacer esta transición hacia la mesa redonda, invitando a que suba José Antonio. Tim, you come to the table. Podemos pasar a la mesa. Él va a seguir dando respuesta a las siguientes aportaciones que vamos a hacer para intentar contextualizar nuestra situación ahora.